You have any questions?
No. After we get through these items, is that your?
I think that's what we should continue to do. So for the public lining up, we're going to do public comment after issue 5, so you can give it all to me at once. Fair enough. Yes, let's go on to issue 2, the SSP program.
Thank you very much. So as you know, the Multipurpose Senior Services Program is a Medicaid home and community-based waiver program whose core service is to provide care management services to frail older individuals who are age 65 and older, eligible for Medicaid, who would otherwise meet the level of care to be in a skilled nursing facility. So these are individuals who have multiple chronic conditions that co-occur, functional impairments, and need nursing supervision. Under California's Coordinated Care Initiative, most beneficiaries in CCI counties must be enrolled in a participating Medi-Cal managed care plan to receive their Medi-Cal benefits, including MSSP. This requirement applies unless the individual lives outside the managed care health plan's covered service area, is awaiting enrollment into managed care, or is exempt from managed care enrollment for any one of a number of reasons specified in the law. MSSP sites serving non-CCI counties continue to deliver MSSP services as a Medi-Cal fee-for-service benefit. So MSSP as a Medi-Cal waiver benefit has cut over into all the managed care plans in the CCI counties. And by December 31st of 2017, the participants in MSSP are then to cut over into managed care strictly as a long-term care management service recipient. That transition has already happened in San Mateo County. So at this point in time, the Department of Healthcare Services, the CCI, MSSP sites, the managed care health plans and CDA are working closely together on issues related to that transition that must occur by December of 2017. We had a meeting in October to discuss issues. DHCS has brought on a project manager to help with keeping us on task with addressing issues, and some of the things we're working on have to do with what are the criteria for local stakeholder processes and continuity of care.
How did the San Mateo transition? How's it working out? How'd that convert?
You know, we recently spoke to Lisa Mancini, who's with the county there, who said that things are working pretty well. As you know, San Mateo is a particularly interesting CCI county because it's a county organized health system, but what's particularly of note, I think, is that the MSSP staff, they continue to offer MSSP as a benefit through the managed care plan, not as a waiver benefit, but through the managed care plan. County staff, MSSP staff, and plan staff are co-located in the same building. So communication is working well. And I think they had some work to do with regards to certification for eligibility, but that's all been worked out between the MSSP staff and the managed care health plan. So our impression from Lisa was that the transition occurred relatively smoothly.
That's excellent to hear. Thank you. LAL or Finance, any comments on that? Let's move on to additional CBAS staffing.
Yes, thank you. The administration is requesting $705,000, $319,000 of that in general fund and $386,000 in reimbursements from DHCS for the CBAS branch within DHCS, gosh, that's a flash from the past.
Right.
Within Department of Aging, I've only been there for 14 years, to support 4 additional positions, 3 AGPA positions and 1 nurse evaluator 2, to ensure compliance with the current state Medi-Cal requirements for the CBAS provider certification, as well as some new federal requirements that are underway. And I think there are like 3 factors that actually have led to this proposal. Initially in the transition, and I know you were well, you remember it well, the transition from adult day health care to the CBAS program, there was a sense that the new eligibility criteria would result in fewer people being eligible for the program, and hence that there would likely be fewer centers. To a large extent, that did not occur, but we actually took a reduction in terms of our CBAS staffing, anticipating that it would occur. So while we have made diligent efforts to try and modernize and streamline and use technology, we continue to get farther and farther behind in terms of being able to do the on-site and the complete certification reviews that we're required to do. We, at this point, I think, are at 80% falling behind. So every year we should be doing half of the centers. To be able to keep up, we should be going out every 2 years. At this point, less than 20% are, in terms of the actual completed process, is occurring in that time period. We're doing the on-sites, but then we get back to the office, and then we need to be going out again. And so the actual completed reviews have really been falling behind increasingly. So we know we can't catch up at this current pace. Secondly, there are new requirements coming that are already in effect and we're needing to implement this year in terms of the new CMS home and community-based waiver requirements. And those will require increased time in terms of monitoring and working with the local CBAS providers, both in terms of making sure that they're meeting those requirements, and then the actual time that's spent out when we're doing our on-site monitoring as well, and following up on any corrective action plans that need to occur. And then the third component, I guess, is the good news. The moratorium in terms of additional CBAS centers has come to an end. We actually have put out the new requirements for providers who are interested in expanding or coming into the program. So we know that we will have additional providers who will be submitting an application, and we'll be needing to go through that initial process and that ongoing process for them as well in the coming year on an ongoing basis.
And will these additional staff assist with the kind of onboarding of the new facilities, or that'll be a separate process?
They'll actually just be incorporated into the overall staff in terms of this. So, and these are permanent positions that we're requesting, since we anticipate that this will be certainly ongoing work.
The agenda references the potential risk for federal sanctions because of the backlog. You're confident that these additional resources will be enough to avoid potential sanctions?
We believe that they will. I always want to put a little caveat, and the only thing that we still are probably not fully have certitude on are these new home and community-based regulations, and there's still a lot of discussion going on between CMS and the states as to the exact meeting. Only one state has yet been approved. So in terms of that, you know, as of right now, we believe that this will suffice.
Any questions?
Ed just reminded me, the other component is that there are also new requirements under the Affordable Care Act for providers in terms of their accountability, background checks, et cetera, to promote greater accountability and root out fraud in those systems. So we know that's another kind of set of workload that we'll be needing to be involved in as well.
Got it. Okay, how about we move on to issue 4, the BCP on Information Technology Branch Staffing, page 51 of the agenda.
Great. This budget request is for position authority for 3 permanent positions in our IT branch. The department will use $423,000 in existing expenditure authority to fund this proposal, but we need the position authority to do so. This proposal would bring our staffing up to the minimum level necessary to meet the state IT requirements, as well as to support a number of the programmatic areas that our IT program has been supporting, both in terms of, some of them are the CBAS program, our long-term care ombudsman, and several of the other programs within the department. This proposal and this staffing would ensure that CDA would have a stable IT network to accomplish this level and to mitigate any security issues that are pending. We are a department that collects personally identifiable information, so, and a HIPAA, it must be in compliance with HIPAA, so these are all areas that we need and have had to certainly do updates, and that will be a continual process given security concerns and network issues for all departments.
Any questions on the money issue 4? LAO, Finance. Okay, we're going to take action on 2 of these, but we're going to wait till after public comment, and then we'll make that decision at that point. Let's move on to issue 5, which are the proposals for investment under this area. And we have, best I can see in the agenda, 1, 2, 3, 4, 5, and 6, correct? 6 of them. So we'll ask those folks to come forward for the proposals for investment. Thank you. And, well, you know who you are. Let's see, the California Association of Area on Aging is going to come to talk about the Elder Economic Security Index, MSSP rates from the MSSP Site Association, long-term care ombudsman funding from the Long-Term Care Ombudsman Association, senior nutrition program from the Commission on Aging, California Senior Legislature has a proposal, and 6, if there's anyone here that would like to present on the advocate's recommendation on the $4 million general fund for Alzheimer's Day Care Resource Centers, let yourself be known when we get to number 6. So let's start with the California Association of Area Agencies on Aging and your $50,000 request to update the Elder Index.
Clay Kemp speaking on behalf of California Association for Area Agencies on Aging on this issue. The Elder Economic Security Index is a tool that AAAs are actually required to use by state statute. And the purpose of it is to accurately measure what the economic status of seniors is in each individual county in the state, which is really valuable to have that local information. The EESI is conducted by UCLA, and what they do is they look at essential costs, those being primarily food, housing, transportation, and medical costs, and seeing what it really costs to live in California counties compared to what the federal poverty level states, which we know is wildly inaccurate, and we've heard lots of testimony today to that effect. This is a very useful tool and it helps us target the services we provide. And if you think about AAA services, they're mainly about prevention and keeping seniors independent and healthy in their own communities. And that saves the state funding down the line in terms of not having to pay for higher-end medical costs. But there's a kind of a surprise positive result in the EESI that we have used a lot locally and statewide, and it's really, from my perspective, maybe the strongest argument of why the state should invest $50,000 in this. The planning purpose that I talked about, that's value in itself. But what we're experiencing is there's an ongoing trend that local government, and especially local foundations, United Ways, and major donors don't want to donate or contribute to senior issues. And one of the things they will cite is that, well, statewide, the poverty level for seniors is 8%, maybe it's 11% in somebody's county, maybe 6%, but that really lowers the priority of funding senior programs. But when we take the Elder Economic Security Index and we can state county by county that in Santa Cruz County, 40% of the seniors don't have enough to meet their basic needs, it really changes that conversation. And it leads to the ability to pull down local money or regional money or sometimes state money in a real significant way. And I think the benefit of that alone on the local level far exceeds the $50,000. It's great to have the state endorsement of this, and that's one of the reasons we're coming here. It's also nice to say a UCLA study as opposed to something that my agency did. It brings it a lot more credibility. So we urge your support of this proposal.
Excellent, thank you very much. We'll move on to the second proposal for investment, and that's the MSSP rates from the MSSP Site Association. $4 million general fund request.
Hi, thank you. I'm John Balutz. I'm president of the MSSP Site Association, and I'm also executive director of Health Project Center. And we run the MSSP for Monterey and Santa Cruz counties. We are asking for $4 million to restore some of the funding for MSSP. This is a program that's been around for 30 years. It has successfully and effectively worked with people who have complex health needs. These are folks, seniors who could be in a nursing home, have a high level of care, and we've proven to be very effective in providing good service to folks. The program has been cut twice, in recent years, and you have that information in the fact sheet, and our rates have been the same for 10 years, and we're getting paid the same to do the same work. We hire nurses, we hire social workers, we have rent, we have purchase services, which is a huge part of the program where we can provide services that aren't provided for Medicare or Medi-Cal to keep these folks who would otherwise be in a nursing home at home. We know that these folks, if they were in a nursing home instead, would cost well over $100 million in excess to what it costs to run this program. We also know that in a survey of our members, the sites that provide MSSP programs, that 2/3 of them cannot run the program and serve the people they're contracted to serve on the funding that they have. We also know that over the last several years that 9 sites have turned over and had other contractors come in. That's not good for the people we serve. We can hear, and for a variety of reasons. And let me kind of tell you about the experience I had in running the MSSP program. The County of Monterey, several years back, eliminated the program. They were subsidizing it to the tune of over $250,000 a year, said, hey, we can't do this, it's not required. Our budget's in a tough place. They cut the program. All the folks on the program were off. They just didn't have the program. We, in time, got contracted to bring it on. And about a year later, we tried to get everybody back onto the program. We were only able to get 1/3 of the folks back onto the program within a year because many of them had gone to nursing homes. Many of them had gone to other places. They weren't able to stay where they had been at home, which is what the program's about. This is about keeping people at home where they want to be and saving money by doing that. And if those folks, if that program hadn't closed, we know that maybe 20% of the folks would have gone off the program. They may have passed away. They may have gone to skilled nursing, something else. But we were only able to find 1/3 of those folks and get them back on. So that's just some indication of the level of need folks have and the the risk we're running by underfunding this program. These are some of the neediest folks we have, and there's no way that the quality of care does not in time erode if we can buy less and do less for people and have staff that can't be on board and turn programs over and kick people off the program who really, really need it. So what we're asking is small, $4 million. This is matched by federal funds, so that'll help beef it up, and that'll keep this program sound. It'll restore what was there and move us forward and to do good things that I think everybody agrees need to be done for folks. So thank you, and I'm going to turn it over to my colleague here, who will talk a little about the CCI in our proposal on that as well. That was addressed earlier by Mr. Long. Thank you.
Before we turn it over, can I ask you a quick question? On the staff write-up references the site closure and turnover of 9 sites since '08. Given your experience when you tried to kind of reopen the site and can only find a third of the people, do you have a sense of the number of Californians that are no longer being serviced through MSSP because of that 9-site either closure or turnover?
Those sites were, to my understanding, were all
Got it.
either
it wasn't
had a
complete
transition,
closure.
so they did not close.
Got it.
I do know that in bidding on it, I think I was the only organization, as far as I know, that bid on the contract, because who wants a contract that somebody was losing lots of money on? Obviously, that's what we do. We were there to do it, and I'm really glad to be doing it. But there is the risk, too, that nobody's going to step up if it continues to be underfunded.
And we could assume that the other sites may have had the similar challenges as you in terms of being able to find folks. As time passed, it had either gone on to SNFs,
Right.
family homes.
It's always a danger.
Okay. All right. Yes.
Good afternoon. Congratulations for hanging in there all day. Madam Chair and member, my name is Eileen Coons, and I am a MSSP site director in Pasadena at Huntington Hospital. We serve the entire San Gabriel Valley. If you know LA, a very large, expansive area, and San Gabriel Valley is like, I don't know, bigger than how many counties, but it's a big territory. We serve 371 people. Back in our heyday, it was up to 465, and so that's another factor in terms of how many less people we're able to serve with the erosion of the funding with the Great Recession, as well as with the rates being, flat funded. And so, I would say as a whole, the providers in this program are passionate about what we do. And what we do is we specialize in serving frail elders and helping to bring the nursing home needs into the home setting, and are held responsible to meet the health and safety needs of our participants, which is a pretty high expectation. So being in a CCI county, just adding to what my colleague, talked about, on top of the already, pretty high bar expectations of the MSSP program being a Medi-Cal waiver program and all the regulations and all the oversight there, which, is a good thing, but it also involves a lot. There's a lot of layers to that. Being in a CCI county also means having more masters. And so our, we used to be solely funded by the state of California. Now at my site, we have 5 other payers that we have contracts with, which when I added up in the last 2 years has resulted in executing, I think it's 14 contracts, whereas it used to be, that would have been 2 in that same time period. We now, in the behest of better coordination of care, which is a very kind of a one-way conversation, we scan and upload, have a person physically standing at a fax machine and scanning thousands, maybe tens of thousands by now, of pages of assessments, care plans, and various forms of documentation to inform the health plans about what we're doing. That's not without a significant amount of staff time and effort on our part. our care managers at my site and other sites in the CCI counties spend a lot of their time now helping their clients, number one, to understand that they're in a health plan. And number two, to understand what does that mean, what has changed as a result of that. And number three, to piece back together access to benefits that they used to be able to get as a Medicare, Medi-Cal fee-for-service participant, because, you know, it's a kind of a different type of fragmentation that's been created with, and I should mention in the CCI counties, I think it's in your materials there, but about 94% of our participants are not in CalMedi Connect. Largely have opted out. Some don't qualify, but largely have opted out. And, you know, I can't say exactly why, but I think what's driven a lot of that is these are people with multiple chronic conditions who need, you know, specialist care from lots of different specialists, and try to figure out what medical group to sign up with and what health plan to sign up with to get that continuity of care is almost impossible, really probably impossible for them to continue to be able to see the different physicians that they're trying to see and receive the care that they need. And so a lot of people have opted out, and what that really means is our staff are on it. We're responsible to make sure that they're, you know, able to have access to their physicians and get there with transportation, that the health plan transportation services, which can be very complex, you know, it's a good benefit to have, but people don't understand what number to call for this, how many days in advance they need to call. Don't call too soon, but don't call too late. What types of things, you know, can they get transportation to see a dentist? Can they get transportation to, you know, for their audiology appointment, or is it strictly for medical, you know, the kind of more traditional medical services? It can be layered and complex, and so our staff spend a lot of times on those kinds of things, as opposed to the complexities in the home setting that we have, you know, more traditionally been very involved in. And so they're kind of trying to do it all. And we used to always say they, you know, did it all, but now I have a new level of appreciation for what other players in the system were doing, or how the system was at least flowing a little bit better. And so what I think that means really in terms of the funding request, the $4 million for the CCI counties, we're still passionate, we're still involved and very committed to serving our participants, with so many that aren't in CalMedi Connect and so many that don't have that potential for care coordination from the health plans. It makes it even that much more important for us to be able to continue doing what we're doing with adequate funding. And so I just would respectfully urge that you approve the funding request.
We're going to move on to the long-term care ombudsman funding presented by the association.